All right, so we'll officially kick it off. Should we get the board? So thank you very much. I at FalconX, I'm one of the co-founders along with and managing partners of FalconX, along with my colleagues Vivek, Lochin, and Angad, and of course have to thank Anuja for the wonderful set of snacks we have here, and we'll wrap it up with a little networking. We've got some wine as well. Cheese. Thank you. What we normally do at FalconX is, work with a focus on B2B startups. We mentor, advise startups. We're adding a new fund so that we're able to invest in these startups also. That fund should be operational for investments by January. So we're in the process of, we're halfway through our commitments for the $20 million fund. But having said that, our entire focus has been around B2B startups. But there are a few exceptions that we take advantage of, which is when exceptional speakers, happen to be in the Bay Area, we leverage that opportunity. And this time around, I took the opportunity of inviting Sunita and Adamuni to be with us this afternoon. There is so much happening in India. I think in the context of the scale of a lot of things, she's been a cornerstone for some of those things in the healthcare space. So I thought it would be very, very valuable to have her talk to us about it. So I reached out to Anurag because FalconX and Epic Global are building on a partnership where we are seeking Epic's expertise and experience in health tech, life sciences, med tech, so that we can nurture and mentor startups with access to this kind of expertise. So when I talked to Anurag, one of the things that we wanted to do in a whole bunch of joint things is they're a volunteer organization, we're a for-profit organization. So let's make sure that it is well understood that FalconX actually has a purpose, but we have a profit motive as well, as we should. Yeah. Now, what we want to blend the two is to make sure that there is a vibrant partnership that allows us to leverage their expertise and also allow them to use and leverage our platform. So it's, a self-fulfilling prophecy of moving this forward. The moment I talked to Anurag about it, he says, I will moderate. So I said, if there is anything that can tie Anurag to a commitment, that is that. So I immediately jumped to the offer, and Sherry was, yeah. Well, I was being a little more. Yes.
The topic is so interesting.
Knowing Anurag, I felt that this would be a great opportunity to have him extract the nuggets of wisdom out of Sunita. And by the way, Sunita also is my sister. We grew up together, and so I've known her from when we were very young. But of course, my focus was on my wife, her sister. So just want to get that out of the way. That being said, I think Sunita and her husband are an example of a significant power couple. They, in 2002, after working for almost 15 years or 20 years in the Valley, they decided to move back and dedicate their entire professional career at that time, 20 years ago, into social impact. And so without, setting things up there, they went there, they discovered India for the first time. And as a part of that, Sunita has done many things. Her husband, Shrikant's done many things. But this part stood out because India's journey in healthcare, as we all know, has been almost non-existent. Mm-hmm. The digitization of that on the new stacks that have been created over the last 15 years is where I felt that the work that they had done was phenomenal. She actually accomplished it as the global head of social innovation at Dell. And so what is important here, and I thought we'll go deeper into the topic, is, India's ecosystem of healthcare, which is a national set of priorities now, is still like a big ocean filled with piranhas and sharks and alligators and hippos. And these are all the bureaucrats, policymakers, et cetera, to navigate and be persistent, survive, and get something off the ground. And I let her talk about how big it has become. This is population scale. And to get Dell as a private industry to commit to that journey is something significant. So what I wanted to do in the introduction was to start this off with a small video that BBC, BBC was curating a worldwide ecosystem of work that was being done for the benefit of International Council of Nurses. And so one of the videos that they had done and that got selected was the work that Sunita has been doing in the context of India's healthcare and the technology platform therein. And this is grassroots. This is not go to Apollo and it'll all work. This is absolute grassroots. So I thought it's a little long video. So bear with me because it'll set the context for the presentation she has for about 10-15 minutes. And then we'll go into a fireside chat because we won't let that be a shallow presentation. We'll dig deep with Anurag on this. So I'll jump into this. Anurag, of course, everybody does know. He needs no introduction. He is the director, professor of the Stanford Biodesign Lab, somebody that does, I think, almost on a scale that matches both of you as well. Very active in the NGO world through Seva International. You're the chair of president of the organization this year, or 2 years at a time.
This is my third year. Yeah.
So and he turns a lot of these organizations into absolute vibrant organizations. So he's never around for us to reach out. So anyway, so Anurag, we're delighted to have you here, and a lot of good things to plan out for 2024 as well between FalconX and this thing. So let me just quickly jump into the video that I had from BBC. Oh,
ನಾನು ಹುಷಾರಾಗಿದ್ದಾಗ ಚೆನ್ನಾಗಿ ಕೆಲಸ ಮಾಡ್ಕೊಂಡು ಹೋಗ್ತಾ ಇದ್ದೆ. ನಾನು ಹುಷಾರ್ ತಪ್ಪಿದ್ಮೇಲೆ ನನ್ನ ಕೆಲಸನೇ ನಿಂತೋಯ್ತು. ಮೇಲ್ ಬದಲಾವಣೆ ಆಗ್ತಿತ್ತು, ಅದೇ ಮನೆಯೊಳಗೆ ಕೆಲಸ ಮಾಡಕ್ ಆಗ್ತಿರ್ಲಿಲ್ಲ, ಊಟ ತಿನ್ನಕ್ ಆಗ್ತಿರ್ಲಿಲ್ಲ, ಏನು ಕೆಲಸ ಇದ್ ಮಾಡಕ್ ಆಗ್ತಿರ್ಲಿಲ್ಲ. ನಮ್ ತಲೆಯಲ್ಲಿ ಏನಪ್ಪಾ ಹಿಂಗ ಆಗೋಯ್ತು, ನಮ್ಗೆ ಏನಾಗುತ್ತೋ ಎತ್ತಾಗುತ್ತೋ ಅಂತ ಯೋಚನೆ ಬಂದಿತ್ತು. ನಮ್ಗೆ ಸುಸ್ತು, ಕೈಕಾಲೂರಿ, ಕಾಲೂರಿ, ಕಣ್ಣೂರಿ ಎಲ್ಲ ಬರ್ತಿತ್ತು. ಒಂದ್ ಸ್ವಲ್ಪ ವೀಕ್ನೆಸ್ ಆಗೋದೆ, ಯೋಚನೆ ಬರ್ತಾ ಇತ್ತು, ಹಿಂಗೈತೆ ಅಂತ ನಮ್ಗೆ ಗೊತ್ತಿರ್ಲಿಲ್ಲ.
One in 5 people suffers from an NCD in India. Like most other countries in the world, India is going through an epidemiological transition from communicable diseases like typhoid, cholera, malaria to non-communicable diseases like hypertension, diabetes, cardiovascular disease, and cancers. NCDs are silent. What that means is that most people, when they have an NCD, don't find any symptoms until it's at a fairly advanced stage.
ನಮ್ಗೆ ಅದೇ ಜಾಸ್ತಿ ಯೋಚನೆ ಮಾಡ್ತಾ ಇತ್ತು, ಹೆಂಗ ಆಯ್ತಲ್ಲಪ್ಪ, ಏನ್ ಮಾಡೋದು ಅಂತಾನ. ಅವಾಗ ಪಕ್ಕದವರೆಲ್ಲ ತೋರ್ಸು, ಸಿಸ್ಟರ್ ಹತ್ರ ಅಂದ್ರು, ಸಿಸ್ಟರ್ ಹತ್ರ ತೋರ್ಸ್ತೋ.
ಸುತ್ತುಂಗಮ್ಮವ್ರೆ, ತಿಂಡಿ ಮಾಡಿದ್ರಾ?
ಆಯ್ತು.
ಹುಷಾರಾಗಿದ್ದೀರಾ? ಏನಾಯ್ತು?
ಒಂದು ವಾರದಿಂದ ಹುಷಾರಿಲ್ಲ, ಕಾಲು ನೋವು, ಕಣ್ಣುರಿ ವಿಪರೀತ ತಗೊಂಡು
ಇನ್ನ ಏನೇನಾಗುತ್ತೆ?
ತಲೆನೋವು.
ಹ್ಮ್.
ಅದೇ ಹೋಗಿ ನಾವೇ ಸಿಸ್ಟರ್ ಹತ್ರ ಹೇಳ್ದು ಹಿಂಗಾಗೈತೆ ಏನು ಸುಸ್ತು ಕಾಯಿಲೆ ಏನು ಊಟ ಮಾಡಕ್ಕಾಗಲ್ಲ ಅಂತ. ಅವರು ಕರ್ಕೊಂಡೋಗಿ ತೋರ್ಸಿರು, ಡಾಕ್ಟ್ರಿಗೆ ತೋರ್ಸಿರು. ಡಾಕ್ಟ್ರು ಶುಗರು BP ಎಲ್ಲ ಚೆಕ್ ಮಾಡಿ BP ಐತೆ, ನೀವು ಮಾತ್ರೆ ತಗೊಳ್ಬೇಕು ಅಂತ ಹೇಳಿರು. ಆಮೇಲೆ ಮಾತ್ರೆ ಎಷ್ಟು ಟೈಮ್ ತಗೊಳ್ಳಿ ಮಾತ್ರೆನ ಅಂತ ಹೇಳ್ತಾರೆ. ಊಟ ನಿಮ್ಗೆ ಏನೇನ ಬೇಕು ಅದೆಲ್ಲ ಬದಲಾಯಿಸ್ಕೊಟ್ರಿ ಊಟದ್ದು ಅಂತ ಹೇಳ್ತಾರೆ.
The national NCD program is working at the grassroots to screen all 30+ population of the country. So the whole idea is that we can detect cancer or hypertension or diabetes as early as possible, so that treatment is much easier.
Digital Healthcare is a technology platform that we've developed for the government's national NCD program. The platform itself consists of a suite of mobile apps on an open modular platform that is looking at improving the delivery of every aspect of the healthcare system for the public health sector. So digital healthcare was created to enable continuum of care for the patient. In the app, there are reminders that are built in that will alert the health worker on which patient needs a follow-up on which day for which disease. And this is very important because otherwise people might miss their follow-ups. Today, the CPHC NCD system has achieved a national footprint. There are more than 135 million people who've been enrolled in the system. The system has been deployed in 32 states across 591 districts, and more than 94,000 health workers and doctors have been trained and are using the system.
Sidama and millions like her probably do not even know that they suffer from chronic diseases like diabetes and hypertension. The CPHC NCD application helps us track every single patient as to their disease status and plan for their individual treatment, not in hundreds or thousands, but for millions of such people.
ಏನೆಲ್ಲ ಬಯಸ್ತಿಲ್ಲ ಅಂದ್ರೆ ಎದುರ್ಕೊಳ್ಳೋ ಅವಶ್ಯಕತೆ ಏನಿಲ್ಲ. ಈಗ ಮೊದ್ಲು ಅಂದ್ರೆ ಹಳ್ಳಿಗಳ ಕಡೆ ಇದೆಲ್ಲ ಇರ್ಲಿಲ್ಲ. ಈಗೇನ್ ಅನುಕೂಲ ಐತೆ ಹಳ್ಳಿಗಳ ಕಡೆ. ಹಳ್ಳಿ ಮೇಲೆ ಸುತ್ತಗಳು ಬರ್ತಾರೆ. ಇವಾಗ ನಾನು ಮೆಡಿಸಿನ್ ತಗೊಂತಾ ಇದ್ದೀನಿ, ನಾನು ಎಲ್ಲಾ ಕೆಲಸನೂ ಮಾಡ್ತೀನಿ, ಸುಸ್ತೆಲ್ಲ ಕಮ್ಮಿ ಆಗೈತೆ. ಕಾಣಲ್ಲ, ತಲೆ ಸುತ್ತಿಲ್ಲ, ಊಟನೂ ಮಾಡ್ತೀನಿ, ನನ್ನ ಆರೋಗ್ಯ ಚೆನ್ನಾಗೈತಿ. ನಾವು ಸಿಸ್ಟರ್ಗೆ ನಾನು ಭಾರಿ ಆಗಿದ್ದೀನಿ. ಆದ್ರೆ ಅವರು ನಮ್ಮನ್ನ ಇದು ಚೆನ್ನಾಗಿ ಇದು ಮಾಡ್ತಾರೆ. ಅವ್ರ ಇಲ್ಲದೆ ಇದ್ರೆ ನಾವ್ ಏನಾಗ್ತಿತ್ತೋ ಗೊತ್ತಿಲ್ಲ.
This has been an extremely enlightening and enriching multi-year journey for us. As a technology company, we saw the opportunity to leverage our strengths and our expertise towards addressing deep societal issues. Digital healthcare is a prime example of how Dell puts its technology, its people, and its partnerships to work to transform lives.
Well, I think Sunita is retired from Dell. The program right now has in excess of about 350 million onboarded into the platform right now. So we'll just jump into a quick presentation that you've got.
Okay, I guess you cannot hear me, right? Yeah. This was a little long. I wish it was like we had a 2-minute version, but hopefully you all got the context. Like Murthy said, I was with Dell for the last 10 years working on public health technology, and I just quit a few months ago, and this is a part of my break. So pleasure to be here with all of you. So digital healthcare is an idea that I started at Dell 10 years ago. And it's basically evolved into a technology solution for managing NCDs at scale, right? So non-communicable diseases, since this seems to be slightly mixed audience, I'll go a little bit into it. India, like most other countries in the world, has gone through this epidemiological transition. It means we've gone from communicable to non-communicable diseases. And some of the numbers there, how rampant it is in India, 63% of the deaths, a big loss to the economy. And three of the things that make them specifically difficult and different from the earlier disease burden of communicable diseases is that they're silent. And I talked about that earlier, right? 50% of the breast cancer cases, 80% of the cervical cancer cases are caught in the third or fourth stages. And by the time your 5-year survival rates are pretty low. They're chronic, which means that you need to manage them month after month, year after year. And in areas where health-seeking behavior is poor, it's very difficult to reach out to people at a large scale, month after month, year after year. Right? It becomes a really big challenge. And only 10% of rural hypertensives, for example, has their BP under control. So they are like, a sitting target for any adverse condition. So if you look at the NCD program, and of course, the third one is they disproportionately impact the poor, which is again not very intuitive. But so if you look to address this problem, the government came up with a national NCD program. They had done this earlier for the last 20 years. They've been looking at this, tracking NCDs, but 10 years ago, the Prime Minister launched this national NCD program at our platform 5 years ago. The difference now is that we said, because of these characteristics, let's do a preventive screening for the entire population over 30. And this makes it one of the largest public health programs in the world, because you're not targeting a specific segment of pregnant women, children under 5, TB patients, which is a much smaller cohort. Here you're saying preventive screening every year for the entire population over 30, which, 350 to 500 million people for those 5 conditions. And that system is being delivered through the government health system. This program is being delivered through the government health system, which is completely free, right? And it's offered for everybody. Mostly, obviously, the poor and the lower income people are the ones who use this. This is what the health system looks like. It starts with village level health workers. There's more than 1 million of them. And then you have the sub-health centers. You have trained paramedical nurses. Who are, there's a new cohort, a new cadre that's been introduced. So they are about 320,000 of them. And then at the primary health center, this is covering a population of 25,000 people. So the village here, this health worker is catering to a population of 1,000. At the sub-health center, they cover a population of 5,000, right? One health worker for a population of 5,000. And here is where you actually meet the first medical doctor, and that's for a population of 25,000. And these are just normative numbers. It's much bigger or smaller in different places.
So the ASHA workers, what's their qualification?
They're not. They probably get like a 6 month.
Fifth grade, typically.
And they're 8th standard plus. Yeah. So they until recently they were just volunteers. So they would get paid an incentive. If you take a pregnant woman for her ANC checkup, you get 50 rupees. If you get a woman to have a delivery in the hospital, you get 150 rupees. If you take a TB patient to make sure they take the medicine, you get 25 rupees. So it's all based on incentive. But these are colors. And then finally, when you look at community district, that's where you get the specialists, the surgeons, the gynecologists, and all of that stuff, right? So there is, if the system doesn't work well, most of these people will end up there. You get a diarrhea. People are very, because health-seeking behavior is poor and people don't understand this health literacy, people end up going all the way up there, right? So the system is not set up for good health outcomes and for reducing the costs. So the basic thing that you want to do is strengthen this. You want to strengthen the primary healthcare system so that you're getting better health outcomes and you're lowering the costs. But the problem with that, with any government's health service delivery, any service delivery, is the quality of the infrastructure, governance, capabilities, a lot of paperwork, citizen lack of awareness. So a lot of issues which are actually common across all sectors, right? So what we did, and I'm kind of rushing through all of this, but we'll go deeper when we talk. So we developed what is now called the National NCD Portal. The video was like more than a year and a half ago. so it called it by a different name. But the National NCD portal, it was based on our work over the last 10 years called Digital Life Care. Basically a threefold objective. For the health workers at the bottom of that stack that you saw, it's about helping them get continuum of care for citizens, right? Continuum of care is month after month, year after year, making sure people are getting the care they need, right? So for health workers, that. For the care providers, that's including doctors, it's about task shifting, making sure that the burden on them is reduced, it's about productivity tools, it's about protocols for standardizing care. And finally, for all the program officials at block, district, state, national level, it's about promoting this data-based decision-making, evidence-based decision-making, giving them dashboards where they can go down all the way to the village level to be able to understand what's working, what's not, and how to allocate resources better. So,
Sorry, did I? Yeah.
So basically, what is digital life care? Each of these colored bubbles is a app, right? And so we have, it's a combination, it's a suite of mobile and web apps that sit on a cloud platform. And for this is the journey that a patient takes to go from the village all the way to the sub-center, PHC and CHC for the NCD care, right? They get enrolled here, they get referred for screening, and then they get diagnosed, and then they go to higher levels for cancer management, and they come back here for management month after month. This journey is where people fall off, right? People go for the first thing, they take the first dose, and then they're off. And that's when the health outcomes become bad. So making sure that you're tracking the patient all through, and then providing the tools. So this is the suite. This is digital life care. It's a cloud platform, single health record with a unique ID for every individual, sitting on the cloud, and tools, mobile, web. It's I go to the next slide now.
Sorry, one quick question. This is very interesting, by the way. So, the 980,000 workers that you have, ASHA workers, they all have a mobile smartphone and an app through which they
not all. And so the way this will work, and if you go to the next slide, the way this works in India is that states are at very varying levels of capability, investments, political will, leadership, lot, right? It varies a lot. So some states haven't even started this journey. Others are way ahead. So we haven't saturated the adoption at all. So today, this number is as of Jan 2023. This is the Dell's audited numbers, but the actual numbers are like 350 million people enrolled and more than 150 million, I think, people screened digitally on the system. And 33 states, the states that are not currently using it are the ones that have their own solution, but they still integrate at the dashboard level. Unique health ID. So this is where the DPI comes in, and I'll talk about that separately when we have time, but all the users. And it's been like a huge trajectory because it's a government program. So essentially, Dell has provided the software, but it is running on government infrastructure. It is run through government health workers and doctors and officials. It is a government program with government money, right? And we are the technology partner. Next slide. So this whole thing is a complete ecosystem of partners. We work closely with Tata Trust. We've been working with them for the last 5 years or more. So they are the field implementation partner. NHSRC, which is government's technical arm on the technology, on the health side, and they come up with all the policy. NIC on the IT side, and then very closely we've worked with the WHO, AIMS, ICMR, Harvard's been doing an optimization study, St. John's Research Institute. So basically, it's a large ecosystem, right? And technology is only one part of it, but when you're actually trying to run a national program, massive national program, then obviously there are a lot of players here who are critical. Some things about the solution. First, if you're talking about health workers going down to every village, there's no guaranteed connectivity. I mean, even in Delhi, you sit down there, and I'm here also, I'm sure you can get
now.
So
My kitchen.
offline apps, and then in local languages, obviously essential for this area. Standardized protocols. We worked with AIMS, head of endocrinology, who came up with a CDSS system, clinical decision support for hypertension and diabetes, and that's been integrated and that's been piloted in Punjab and will get rolled out across the country. So capture of medication prescription, a referral workflow, this is absolutely key. So when the person is going from the village all the way to the, let's say the district level, at any point, because you have multiple care providers who are providing care, you want to know where the patient is and what kind of care they're getting. So they're getting screened here at the subcenter level. They are getting diagnosed at the district level, right? That information, that referral workflow is absolutely important. Right? And that's been, like, I think, the biggest challenge in having one. It's not a disparate set of apps. It's one solution with multiple apps for each of these workers. A longitudinal health record, a dashboard that will allow them to drill down. So this is another very key thing. When you're looking at government officials who are running, and I give this example, before we had this, spent a lot of time, obviously, I've trained 500 to 600 health workers myself personally, and worked with a lot at the district level officers. And when they are doing their monthly monitoring review, the district health official will sit in a room not very different from this, maybe slightly larger. There will be 200 people because a district might have, like, let's say 80 to 100 primary health centers. So from each primary health center, 2 people will show up. Each of them manages, will bring a pile of like 50 forms, right? A health worker manages 50 registers.
I can
So
vouch
they-
for that, right?
Yeah. So they come with this aggregated data, 50 forms. And this person sitting here, like Anurag is sitting, and managing, conducting this review for like maybe 2-3 hours, is making decisions on performance, because their entire budgets, allocation of resources is based on performance, right? Is based on these sheets, these piles of paper on each of these things. How do you work like that, right? How are they supposed to make decisions? So this dashboard will drill down to village level, because dashboards have been around for a while. So when the government has been trying to work with this, data, but what happened when you don't have data coming, individual level data coming from the bottom, it's people are filling out forms. You sit under a tree and you said, yeah, 10,000 screened. And you just submit that, and then whatever. And so at somewhere up on top, it's getting digitized, and you get these fantastic numbers, right? But the health outcomes are poor. So the ability to drill down all the way to village and to an individual level is, I think, is the game changer, right? So no more. In fact, a lot of the work that we do is also policy work, pushing guidelines. So one of the things we pushed a lot, saying, when the states are doing their annual budget planning and they're getting reviewed at the center, and we participate in many of those, that their performance numbers should be coming from these dashboards, which is aggregated data coming from data at the bottom, so that there's no fudging here, right? So these things will start pushing for better adoption at the lower levels, right? So these are some of the things that was launched by the PM, the different things that have happened over the last 5 years. We've done a lot of papers, case studies, presented at the G20, like 2-3 such presentations over the last year. Yeah. Some dashboards. This continuum of care funnel is a very important thing, because it's basically saying, of the people enrolled, of the people, total target population, this is how government works. So states are all chasing targets, right? So of the total people in the population, how many are enrolled? Of the ones enrolled, how many are screened? Of the ones screened, how many got referred? How many got diagnosed? How many got treated? How many are on follow-up? And finally, the final golden, the holy grail that we're all chasing is, how many hypertensive patients, for example, have their BP under control? That's the outcome, right? You can do all of this, but if you don't get that BP under control, then you're
I don't want to keep the only person keeping interrupting, but this is fascinating.
Yes.
So at the grassroots level, how do you get the enrollment to happen? How do the ASHA workers, do they go house to house saying that this is the time for checkup, or how does it work?
So the program is designed, this is independent of the technology. The NCD program is designed for universal enrollment. So the ASHA workers go door to door, and they could do that anyway. That's a part of their job. So there's something called a community needs assessment that happens once a year, where they collect information about the household, and they use that as the denominator for all the targets for all the programs. So like NCD, the non-communicable diseases, there are a bunch of vertical programs that are delivered by the health system. TB, leprosy, blindness control, that like a whole RCH, reproductive child health. So for all of that, they need to first understand what is the denominator, who is the population. So they do that, right? Now, obviously, everybody's trying to automate all of this. But when they go door to door, they will do specifically for NCD, they're interested in the population over 30. And they do basic risk assessment. And then they send all of these people to the sub-health center, which is run by the A&M and the community health officer for screening. And some places they do screening camps, some places they go door to door. So they have different models because health is a state subject. And then they get referred to higher levels if they need to. Yeah.
So, following in the same line, do they collect the data digitally or do it stay on paper?
That's a good question. So it's mixed, right? There are some places where, again, it's a lot of it is the leadership push, right? In some cases where they're very, the states are fairly mature in terms of digital literacy, and they're actually capturing it by phone. Ashas and ANMs tend to do that well, but in many cases they collect it on paper and then they go enter it, but it's still individual level data, which is important. So these are all the thing that, we've learned that none of this happens overnight and it doesn't happen at a go. You get these massive scale, but it's like slow incremental progress. We found that for a couple of years, the states were only focusing on enrollment and screening, right? They were referring to the higher levels and people were going there, but the data entry by doctors, and I'm sorry to say doctors are so hard to deal with in terms of data entry.
That's universal. Sorry.
So, sorry, doctors. But and then for ease of management, the districts, the states were pushing for enrollment and screening being digitized first, right? Yeah. And then we started pushing, saying there's no continuum of care if the doctor doesn't enter the diagnosis. You don't know who's got diagnosis, and that's it. You're falling off the track. So you had to push that, and that comes. So initially we thought, okay, if the doctor said we want mobile apps, we don't want to do a web app and all that. So we created that, and then some other excuse, right? So then. But it has to come from the top down, and they say, no, you have to do that, right? And they said, we want a data entry operator.
Can I realign ourselves into the format that we designed? Because I want him to start
I want to
asking
make sure.
questions.
So if you have questions, please
Write it down.
We'll bring it up during the audience part of it. Let there be a flow. There's a particular flow that we want.
There's a plan.
Okay. So these are the dashboards. Yeah. Next slide.
Is that it or no? Okay.
Yeah. And so this is what Tata Trust does, right? So we develop the technology, but then it has to actually be rolled out on the ground. Yeah. So they have a tiered model, a cascade training. This is a very traditional thing, hoping to completely revolutionize this with GPT and all the new cooler things that are happening. But government still works like this. So there will be master trainers, and then they will go and do district level. It's a cascade model. And there is a cascade model of support also. So we have a technical support unit, and a lot of this we have to do. So, like I said, technology was only one part of it. A lot of this is setting up in Delhi, the call center in multiple languages, setting up the technical support unit, the data center, the infrastructure management, and the ITTSU. And then how do you actually, what are the SOPs that you have for the way issues get escalated all the way to the top, get resolved? How do you choose what gets actually done? Because the pressure is enormous from the states. And if you don't respond to them, they'll immediately write to the center saying, we asked for this and this is not happening. And the 33 very vocal, very loud states, all putting pressure on a CSR team. So you can imagine, right? So these are just some field pictures. Every one of my team spends a lot of time on the field when we're building this. Yeah, this is a typical data. We can skip this.
Yeah, that's it.
Yeah. This is that was a Ayushman Bharat Health and Wellness Centers, and this happened in 2018. The part of the Ayushman Bharat scheme, which was launched for the year. Yeah. Okay. Well, like I went really fast.
Well, thank you so much for that, Sunita. This is phenomenal, and I've lived this for 17 years. Last 17 years. So I know, I could visualize everything that you were describing. Phenomenal work. the numbers that you're talking about are, of course, India is a large country, so of course, numbers going to be large, but to be able to do that with that large number is pretty phenomenal, and I'll come back to that. Let me just actually.
Can you get your chair this way, because we're recording it, so get closer because we don't need.
Let me just actually provide a little bit of a context to what Sunita talked about and why this is so phenomenal, and the challenge of India and the opportunity it presents and how it actually relates to what we have to do with the world. So we are 8 billion people in the world. 3 billion out of them have some meaningful access to healthcare. 5 billion don't. And a couple of billion within those have zero access. So it's a pretty significant problem. A large part of the humanity doesn't have meaningful access to healthcare. And it's not just rural India, it's Africa, it's 100 million right here in the US, rural United States. And a big problem has been that healthcare has moved from being community focused in 20s, 30s, 40s, 50s to more tertiary care focused, because a lot of technology, ironically, actually moved us. We had big CT scanners, big X-ray machines. So technology is what moved us to bigger centers, and people started coming into these centers. So if you go to China 20 years back, everybody was coming to Fuwai and Shenzhen and east coast of China, and most of China could provide meaningful care. So technology actually became the driving force from this distributed care model care to centralized care model. Fast forward to 15, 20 years back, when it became clear that technology can enable care closer to home, digital health, and which was not even a term then, or diagnostic technologies that are more like pregnancy tests, which is a stick. 50 years back, that wasn't there. So slowly you're starting to sort of create access to healthcare in remote settings, in your home, in your communities, through technology. So that promise started becoming clearer 20 years back, of going back to the future, if you will. But challenge was a lot of this technology is not adopted, and healthcare system is still, top down. It's very tertiary care centered. It's not community centered. It's not human centered. It's not, people centered in a way. So the context that I wanted to provide to everybody is that this is a phenomenal reimagining of healthcare on the backs of technology. And for a technology company, foundation of a technology company to sort of come up with that and work with the government of India, it was amazing. And you started that 10 years back, 2013. Just to provide a little more context to that about India, you're right. India did not have a meaningful sort of innovation in healthcare for a long time. When Stanford Biodesign started working in India with AIIMS and IIT Delhi in 2007, there were not that many health technology innovators. Today, India has 1,000 health technology innovators, nearly 1,950. Couple of hundred health technology companies. 75 of them are actually commercial stage, touching 10 million lives or more. So it's a very different place today. And yet the challenges are huge, as we can talk about, right? So my first question to you, Sunita, is that this is wonderful. It's a lot of work. I can imagine how many different people were involved. How many, it's good that you still have black hair. I mean, I can imagine.
That's genes, right? It would have all been white.
It's remarkable. So you must have a hack to sort of manage the stress, because dealing with policymakers, this complex, health is a very complex field, even in this country. In India, it becomes even more complex. How did you decide which states were you going after first? And which were the states where you had an easier time doing this, and which states did you not?
So I was just very, very opportunistic, right? Being very, just when I first started this as a pilot, after we did, the first pilot was done with a bunch of volunteers from Dell, because I didn't have a team then, we were just an experiment. And then had the opportunity to present it to Chandrababu Naidu. He was visiting my husband's office. My husband was with Aadhaar, head of technology at Aadhaar. So he was visiting there, and I said, I need 10 minutes. I need 10 minutes. So I squeezed that, you have to play any card you get, right? So, and then I showed this to Chandrababu Naidu, and I said, I'm from Vizag, and Vizag had just had a cyclone thing. So I said, we'd love to help. And I'd already talked to my EMC, the management, saying, guys, can we please do it for free for one state? Because if we don't do it, we're not going to ever be able to show scale. So I got their approval, went and pitched to Chandrababu Naidu, and he said, let's do it. Before that, I'd been pitching to a whole bunch of states and got absolutely no. 10 years ago, there were very little takers for technology for government programs. They just saw that as like completely inconsequential. So once I got one person and I got to do that at a district level, then we scale it up to a state. Once we got one state, see, the thing in government is they trust only other government people. So I could have done it at a very large scale with an NGO. It's still very hard to get the credibility, but I do it in one district, in one state. Suddenly the other states will be, because they know their peers, their fellow IS officers. They go, so-and-so is doing it there. Okay, I can do it here too, right? So that really worked. And then we went on to, and center only, there were like some 20 people, 20 organizations who were trying to, when the center was looking for a national solution for the NCD program, there were like 20 people, everybody offering their solution. What allowed us to eventually get it was the fact that we had done it at Andhra at state scale. Nobody else had done it at a state scale. They'd done it at...
So the ground up was important.
So the ground up for us worked because as EMC, Delhi EMC, we had no credibility as a healthcare organization in rural India. None, right? We are a technology company developing, servers and storage and all of that stuff. So for us, different organization might have a different path, but for us, this really worked.
Can I just double click on that a little bit? Walk me through the first few months of doing this. You worked with district collectors, you worked with health officials, you worked with health workers. What did it look like in setting this up and getting it going?
When I was working with Government of India or when we
No,
started?
at the district level.
When you started the
First-
When
program.
you started the first program, yeah.
So when we first started, we started with an NGO called Karuna Trust, right? And they are, I don't know, many of you might know, he's fabulous work in rural India with tribal areas, right, in Karnataka. And he's somebody I've known when I used to live in the US. We used to support their work. So someone I've known for a long time. One of the few NGOs who was also at that time very open to tech, right? So he had a primary health center, which was his little, lab. So I said, Dr. Sudarshan, you want to do this? And I have the buy-in from my company. Let's build something. So we actually sat, Anurag, for the first version, we sat with the health workers. Every week I would take my team, my volunteer team. That's the only thing I had funding for. I would take them in a cab to Gumballi, which was this particular PHC. These guys are all from different parts of India. Many of them had never been to a village. This is urban India, right? They were like, oh, this is also different. So we'd sit with the health workers because I'm like, the first time I had a meeting with my volunteers, they're like, cool, we do a mobile app. Give me the, where's the PRD, where is this? I'm like, just come there. This is not going to work like this, right? So there's a huge gap. And that is, I think, is the challenge.
Yep.
There are not too many people who straddle all of these,
Yep.
right? And so tech people don't understand this, government people don't understand civil society.
Huge one.
Yeah. So the reason I wanted you to walk through that journey is because the key point that I want to bring out from your work is that it has to be needs driven. I think most folks don't, in health technology especially, people don't understand unmet needs very well. And unless you go into the clinic, unless you go to the primary healthcare center, unless you go to the villages, unless you understand the social determinants, and you brought up some of that, and you didn't use that phrase, but it's there. And I'm going to come to that as a separate question. But that unmet needs, deep understanding of unmet needs, the context of those needs is critical before we come up with the technology solutions. Technology is not a solution. So let me come to that second piece.
Yeah.
You said technology was just the beginning of it, just a part of it.
Yeah.
Can you talk about what else was required to make your technology a solution? Because technology by itself was not a solution.
So many, right? So first is the program design itself, right? So Government of India had come up with the NCD. So their booklets published. This is a standard thing. I think I had a picture of one of those. So when they designed the program, they come up with these booklets, right? And they said, we want, because of the PMO, the current government is very, into technology. And so they said, we want a technology solution. But if you take those guidelines and you try to convert that into a technology system, it's like impossible, right? You know how specific and you have to be if you're trying to develop a technology solution. The guidelines are pretty broad, right? And by working closely with the Ministry, WHO, AIMS, NHSRC, all of the people who are responsible for those guidelines. And when we tried to develop a technology solution, we kept asking questions. Well, but what if this happens? then what is the health worker supposed to do? That's what the technology solution will need to do. If you don't have a health worker and she's transferred, what happens? Who's supposed to enter it? So they were like, yeah, I mean, those were not there specified, right? So we had to push very hard on the program design, on what do you do, and all these hundreds of exception cases, right? And they would be like, you guys are making us do a lot of work on the design. The second is like the policy level stuff, right? A lot of work that we needed to do on policy. The doctor data entry was one example, right? Saying that, how do you ensure, when we found out in the field, we would go to the field all the time. And so I would ask them, why is there only entry? I would ask the health worker, you guys are entering enrollment and screening. Why isn't the diagnosis and all entered? And they said, oh, our district health officer, they said, you only focus on this. And then you ask the district officer and they say, because the conditionalities, and these are payment, budget conditionalities. So Government of India will pay the state for the performance of these two conditions. And diagnosis and all was not condition. We ended here, you do the rest of the work, but don't bother about entering. So we had to go push for conditionalities to include entry of diagnosis and treatment. So, I mean, these are examples. The thing is, it's not easy for government to push for everything at once because these are massive. You're talking about hundreds of thousands of workers and district officials. So everything happens incrementally, but you have to straddle all of it to give the right. It's very important to give the right input at the right level. You want UX input, you go to the field. Don't let people in Delhi sit and tell you this, right? But if you want policy input, then every state will have its own idea, but you go back to where it matters. So that was another thing. Infrastructure was a massive amount of work. This has to be hosted. Things that you would take for granted. Oh, just put it on AWS. Nobody thinks about that, right? Enormous amount of our time and effort went into the infrastructure because this is hosted in a government data center, and then and rightly so, a lot of policies on how the infrastructure, how new storage is added, whatever, like everything is to go through a lot of policy. Enormous amount of my team's work went into that. The training and field capacity building, prioritizing. I was just alluding to that earlier. When you have 33 states and everyone is pushing, saying, I'm going to do, they all do campaigns, right? That's a way that you do a massive, push for a particular program. So let's say that the state health minister is they're for whatever reason, they're very keen on doing NCD. They want to put a focus on NCDs, or pregnant women, or whatever, right? Then they'll say, okay, we're going to do a 3-month campaign on NCD screening. And that's it, right? If it comes from the political side, then everybody has to implement. So there's a 3-month campaign. And now for that, everything has to gear up. Because in the 3-month campaign, the MD, and the commissioner, the secretary, at every level, they are now monitoring it on a daily basis because the health minister is going to ask for daily things. So they are now saying, we want daily reports from your dashboard. Like, infrastructure, sorry, does it for us to be able to do daily reports, we need a huge amount of infrastructure. So we have to do a lot of jugaad. Well, the rest of these states are sleeping right now, they're not doing much. Okay, remove the resources, make sure these guys get their daily things. During this campaign, you support them. So you have to understand government, you have to understand the field, you have to understand technology. So there are all of these pieces, right? And so the technology development, prioritizing, every time they finish a campaign, they come out with saying, these are the 20 things. They literally, you go for these meetings, they say, Sunita ji, here, and they come out with something. Like, and then we used to tell the center, we can't respond to all of these things. They just talk to Delhi, right? So then they'll all write letters, and then we have all these things. So prioritizing what to build and that whole pipeline too. Again, a lot of these work very differently from a typical startup or a private sector, system. So you have to understand how it works. But the also beauty is that if we are able to convince for one particular thing that needs to happen, like, we want to make sure that sub-health center, the ANM is able to do the entry on behalf of the doctor. Let's say some such thing, recommendation, we found that working on the ground, we found a best practice. we convince the joint secretary, he says, draft the letter, we draft the letter, it goes out to all states, boom, right? So that's the advantage also when you work at such a scale that these things, you have, that's why it's difficult because you have to follow all these processes so there's no abuse. But if you do it all right, then you get that.
You get the scale. So that is a great segue to my next question. I'll just ask two more and I'll open it up to the audience. I'm setting it up actually. You do this grounds up, understand unmet needs, which is what biodesign philosophy is focused on, come up with a prototype, what works. You may manage your stakeholders, you build infrastructure, you have program design, you work with policymakers, you do training, you do all of that, and you build that rev one of the solution, minimum viable product, or what you want to call it. And then you demonstrate that this works. It does what it's supposed to do. How do you then scale? How did you go from that district, rest of the state, to other states? Can you walk through that journey?
Yeah. So when we did that in a district, first district with Chandrababu Naidu in Andhra, we went all out and we kind of knew. I'd been working in the development sector for.
This is the Andhra before it became Andhra and Telangana, right?
No, it became
this-
Telangana.
It had already become, okay.
It just happened.
Okay.
I had been working in the development sector for a while, for 10 years before that in water. And so I kind of had a very good understanding of the development sector. So when we started working in Andhra through Dell, I knew that building the technology doesn't mean anything. You can build it, but you really have to, like you said, it has to come from the ground. You have to understand the needs and you have to support them in the adoption. Because adoption is a massive challenge, right? You have to support them. So we spent, and because it was a district program, we didn't have the push of the entire state machinery because it's only for that particular district. So the district health officer, they have tons of, everybody has a ton of other things to do. So they are not going to go and help you shine in your particular pet project, right? So it's up to you. So we went to Vizag, every district. I'm from there, but I've never seen any those parts. I mean, every part of the district. I never seen it until we did that. Every corner, and we trained people ourselves. That's where all the training happened, right? And we trained them ourselves. We did the support. We did the adoption to make the whole thing succeed. So if we had gone and saying, we are the technology partner, we are giving you a technology for free. Here's the technology. You don't use it. You have a problem with training. That's your problem. If we had done that, then I wouldn't be.
It would be dead by then.
It would be dead immediately,
yeah.
right? So we knew that if we have to make it succeed, we have to do everything. So technology, what we did was way beyond our remit, way beyond, right? But we wanted it to succeed. We did everything. I would sit with the principal secretary or the district health officer for their reviews. Like everything, the training in the field, all of that. We would write down specs for whatever, or letters or whatever they needed to do. We did all of it. But that, while that program at the district level didn't go very far, after that, because these things usually have to work at state level. When the next year, Chandrababu Naidu wanted them to do NCDs across the whole state for women over 30, the principal secretary said, I want to work with these guys. Because she'd seen us, we've interacted with her. So that opened up the state level opportunity. And when she was a very, very good principal secretary, and she had high credibility in India, when we did it with her, and that was very, very demanding because they are extremely rigorous. Chandrababu Naidu's review meeting, I remember one meeting started at like 8 in the night. We were waiting the whole day for 4 or 5 hours for him. When he came at 8 and went on for 2-3 hours. And he would review every 2-3 months.
That's amazing.
And before his review, you would have the minister review. Before that, you had the secretary review. Before that, you had. So these were like, but on top, he would ask. Anyway, so the point was that because of that rigor and going through and making that successful, that then, opened up the doors for Telangana and then that for the center. So, and once we went to the center, once it was adopted as a national thing, and that took like a good, many months. The signing actually took like a year, long after it was launched by the PM. The actual signing happened. But once that happened and we became the official technology partner and this became the technology solution for government, then it rolled out to all states, like instantly. It's available to every state.
And was this part of ABDM or was it part of NHM?
ABDM didn't happen. When we started, there was no ABDM.
Okay.
Right?
Ayushman Bharat Digital
Sorry,
Mission.
yeah.
Sorry,
So this is the whole digital public infrastructure, which is a whole separate.
Which I'm going to come to.
Okay. So so when we started it, there was no digital public infrastructure. So we had to build the embedded digital public infrastructure, like a unique health ID, unique health record,
The stack.
and the registries were all a part of our system, working with everybody in government, right? So, so we built that embedded in this, and then when ABDM happened, we kind of.
So it was which
implemented that.
program within the federal government, the central government that actually put that forward, basically adopted this? Was it
This is only the
NHS?
NCD program, the
NCT?
non-communicable.
Okay.
So this, the
So
name.
for
of the
Ministry of
program-
Health though.
Yeah, it's all under Ministry of Health and Family Welfare. Yeah, so I should clarify that, the Ministry of Health and Family Welfare. And the name of the program is the National Non-Communicable Diseases Management, Hypertension, Diabetes, Oral, Breast and Cervical Cancers, Preventive Screening, Treatment, Management.
Very good. So that brings me to the last question. You scaled it up. You demonstrated at the district level, you understood the need, prototyped it, demonstrated it, state adopted it, multiple states adopted it, federal government, central government adopted, made it a formal part of its plan. And now you have the numbers that you do. Let's talk about the sustainability of this and what does the future look like. There are two parts to this particular question, and I'll go to the global impact, because there's a potential for this to go globally to Africa and other places that I've worked in where I see this being quite useful. So I'll end with that and then I'll open it to everybody else. The two parts is, one is the quality of data. I mean, I've worked in rural India quite a bit. I worked in rural China, and I know that data, the quality of data, what people are putting in, it can vary quite a bit. These ASHA workers, they have a lot to do, ANMs, they have a lot to do, and they don't necessarily get incentivized appropriately for some of these data entry and appropriate reporting. In fact, sometimes there's a disincentive to reporting, certain kinds of data. How do you make sure that the quality of what you're getting, because it's really centered on that quality of information you're getting, and that real-time decision making that happens, and then flow back to action on the ground? How do you make sure that that data is solid?
Yeah. So it doesn't happen right away, right? So this is the journey that every program will have to go through. It will take time to mature, right? So you will have to allow, because the enforcement, the push for the pull for the quality will have to come from the state and central functionaries. It can't come from anywhere. The health system has to become stronger, right? I'm also on the board of another organization called Health System Strengthening Platform, and the focus is really, you eventually, for sustainability, the health system has to function without external actors trying to do it, right? So for the quality of data, that has to come from two angles, right? One is from the patient, who, if they are a part of this whole ecosystem, they can say, no, I didn't get my screening, but this thing
Says that I have
shows
screened
that I've been screened this year and I haven't yet, right? So that is a very
So an
strong
aware
way.
consumer.
Triangulation, right? So that is one. But for that, health-seeking behavior, health literacy, all of that has to improve. The second is obviously from the leadership is everything. When you have a strong MD, things dramatically move, right?
MD-NHM.
MD-NHM for
So this is National Health Mission, which each of the states has a version of it, which does a lot of public health. Sorry, we using terms which are we're familiar with,
yeah. So
and MD is managing director.
yeah.
Sorry.
So all the commissioner, the secretaries. So if they at the state level, if they are putting the push and they're putting the pressure for quality, then everything acts. People are not going to do it because there's so many other pressures, right? So these things, like I was talking to one of a very senior, government person about this, and the thing is, said that these things go through waves, right? You have to first focus on basic adoption, and then as a second level, then you start looking at, improving the quality, because it requires that level of maturity and for all of these people to then put the pressure, and then the system will respond to that.
Makes
right?
sense.
So that is how
Makes
it
sense.
would work. And so some states are doing it. Again, it varies. Some states the quality is better. Some states.
Yeah, maybe in the after we're done in the reception, I'll ask which states are still not doing very well. We probably don't want to on record.
We should talk about that.
So the second part of that penultimate question that I have is, screening and diagnosis is important because if you don't measure, you can't fix. I mean, it's a known in global health, which is where I come from. It's a known phenomenon that if you don't measure it, you can't fix it. And that's true in life in general. This is why having, Fitbits and, all of that actually helps behavior change. But you also need to follow that up with interventions.
Yeah.
And often those interventions, like I said, because of technology, because of clinical infrastructure, is all secondary and tertiary care.
Yeah.
It happens at AIMS, it happens at GPGI, it happens at all those institutions. Intervention capacity doesn't exist at the community level. But as I mentioned in my opening comments, there's now 1,000 health technology innovators that are actually bringing in interventions, technology interventions that could actually do things closer to the community. Do you see that complementing the platform you've built to build, these ASHA workers and ANMs actually doing interventions? So not only are they doing screening and diagnosis, but they are now empowered in the flipping of the healthcare delivery model. Now they're empowered to provide the quality of care and intervention that could in the past be provided. They can't do, TAVRs, they cannot do surgical, they can't do cabbages, but they could do potentially basic 80% of the disease conditions can be intervened on in that last mile. Of course, these are not doctors.
Right.
Can you see that? Can you foresee that happening?
So I think definitely, I mean, if you look at the kind of innovations that are happening with technology, I think that's the direction we're heading in. And this is a good segue into ABDM, right?
Yeah.
ABDM is the Ayushman Bharat digital mission. So I'll just spend 2 minutes on digital public infrastructure. Right? So India is kind of leading the charge globally on this whole idea of digital public infrastructure, which is basically saying that let's move away from these siloed, fragmented solutions that have been happening, not just in government, but everywhere, right? But primarily in these last systemic kind of spaces, siloed solutions that are happening, and say that UPI is a great example, the Unified Payments Interface, that if you have a digital public infrastructure, which is kind of like GPS or, like how Uber and all got built on the low levels, right? If you build the common standardized specifications and interfaces, then anybody can build their innovation on top of it and it will automatically be interoperable and will be portable, right? That's the general idea of digital public infrastructure, that you don't want to have even a platform. Apple is a platform. These platforms all end up, Facebook or all of them, they're platforms that capture value and they monopolize and they hold on to data. And DPI is moving away from that, saying by having a standardized platform with a standardized set of interfaces and specifications, anybody can build it and two platforms can share data, right, with each other, and you can have truly innovation because the entire heavy lifting is being done at the bottom as the infrastructure. So in health, it's the exact same thing. The idea is that if you have a DPI for health, a patient can go today to an Apollo, then to a Manipal, and then come back to the public sector hospital because it's the cheapest there. And the health data is seamlessly flowing across all three. And you want that to be enabled. It's not in anybody's interest except the citizen's interest. Certainly not in the interest of the hospitals, right? And this is why government has to own it and drive it. And that's what happened for health. So ABDM is Ayushman Bharat Digital Movement. That's the DPI, the Digital Public Infrastructure for Health. So what it does is it has all the foundational elements like health ID, which is now independent of any platform. You have to have a health ID that's common, irrespective of which platform you're on, which provider you're going to. Registries, the registries is the list of doctors, list of health workers, list of facilities. Again, that has to be common across one standard, single source of truth for the whole country. And then a consent mechanism, because all of this has to happen only with the patient's consent. My data shouldn't go between Apollo and Manipal and thing without my consent, right? So all of these are a part of ABDM, and now anybody can innovate. So the kind of things you're asking about, Anurag, is exactly the kind of innovation that ABDM will allow. So I certainly see that happening. Today, government programs tend to be very government-centric, and private sector does their own thing. In reality, people are going back and forth, but the health system doesn't cater to that kind of movement, but ABDM.
Well said. And I will say just one comment. DPI and DPG and a number of ministers have come to the Bay Area last 18 months. We have hosted them at Stanford, and they've talked about this. And you're just corroborating a lot of stuff that's been heard. It's one of the most radical, most disruptive innovations in health, as in finance. It's decolonizing and deconstructing the very siloed, very stakeholder-driven intervention or healthcare system. I think it's going to dramatically alter what healthcare becomes or the future. I believe it's a solution for the world, not just for the global south, but also for global north. We'll see that happen. I think next 20 years are going to be whoever is interested in being, we don't have too many young people here in the crowd, but those who are interested, if they are watching this, if you want to become a doctor, you're looking for clinical medicine, healthcare is going to change dramatically in your lifetime. Last question, and then let's open up to the audience. Where do you see this with the DPI and the DPG, frameworks coming into play? You having done what you've done, and now all of that potentially residing on ABDM. Where do you see that going outside of India? Do you see this being implemented in Africa as is, modified? What does that journey look like?
Yeah. So my role at Dell until a couple of months ago was the global head for social innovation. So it was in my mandate to take what we had done in India, because everybody at Dell was super excited by it, to take it to other countries. Because at least LMICs, the low middle income countries, have the same kind of health system.
Those 5 billion people who don't have meaningful access. Yeah.
And they have the same health system structure. So this is really a good fit. So we've had lots of conversations with countries in Africa through WEF, surprisingly, World Economic Forum, through, WHO. We presented to the whole CRO region, CRO Southeast Asian Regional Office of the WHO. So to those countries. So we've spoken to many, many countries. I spoke to a group of California senators, Democrat senators, who came visiting Dell in Bangalore a few years ago, and I presented this to them, and they were a whole feisty bunch. I love them, right? So they were like, come and do this in California. I'm like, seriously? You guys are serious? They're like, no, but we need people who are able to speak our language and understand this. They got everything that I was talking about. Sometimes it's harder when you're talking to pure corporate types. They don't understand the context very well. These guys were like, yeah, we totally get the problem, health-seeking behavior. How do you make it universal? How do you reach out to everybody? Totally got it, right? So the thing is, yeah, I was already looking at that while at Dell to see how we could take it to other countries. And we looked at a lot of African countries, the different levels of maturity. None of them are close to DPIs the way India is at all, right? So in those cases, you're not going to get digital infrastructure with health ID, registries, and all that clean. So unfortunately, it'll still be fragmented. Though they have ideas, they've all heard these words, so they're excited by it, but it means also connectivity has to be good. The institutional maturity, you need to have the institutions that can actually make DPI happen. You need to have the budgets for that and all of that stuff. They weren't quite ready, so it would have, what we were looking at before I left was actually taking this solution, and we even were looking at a lighter version of this that we made, because this was heavy for India, and many of these countries are 20 million, 50 million. Taking a solution built for 500 million, it just becomes too heavy. So, but I think that, a lot of these efforts, we were collaborating with some people who were already trying this in other countries. I think that I'm not so convinced that taking the software as is the most important element, right? It's not like, oh, you guys have invested all this time and you built this software, now can we go use it in every country? Because it's software and not the whole thing.
It's the overall architecture.
So in fact, if you have the really clean specs and the technologies have changed so much, it's much better to rebuild that very quickly. The part that takes a lot of time, which you can kind of reduce by going to another country, is the understanding of the systems. How do you convince people? How do you design the program so that they can do it quickly? So it's not so much about that technology, or you've already built it, you've invested all this time and money. The time and money didn't go into just building this technology, right?
Yeah, everything else that you said, program design, policy, infrastructure, training, stakeholder management, all of those things. Good. Okay, with that, I know we ran a few minutes later than what I was planning, but Let me open it up to the audience. This is a very rich conversation. You can tell that I'm very fascinated by it, I'm excited by it. This is part of my own charter as well at Stanford.
Like you said, I can't believe we haven't met earlier.
I know it's shocking that we haven't met, but I think we know lots of 150 people I saw that are common amongst us between the two of us. So I think we have a lot more conversation to do. But please, Himanshu.
Thanks. Thank you for the eye-opener. Now you talked about the information flow and the system behind it. My question, I have actually two questions. I have many more, which I'll talk to you later about. But first two questions. What about, you talked about some of the NCDs, but there are other cases of like TB or leprosy. Are they also built on the same stack, or are they working on a completely different platform? How does that work?
This is, sorry, you want to do your other
Yeah,
question?
and I wanted to understand if that can be extended to any sort of a program. Like, for example, we work specifically in the area of pediatric cardiac healthcare. There is a program built by Kerala government called Vidyam, which tracks, again, from the child's birth to the primary, to the secondary, to the tertiary, and then to the village nurse throughout the life of the child. So how do you use this kind of a platform to or leverage?
So when we started first working with Karuna Trust, the first thing like 10 years ago, we were looking at a comprehensive primary healthcare because our analysis after talking to a bunch of stakeholders was this fragmentation is creating a lot of problems. I've talked to joint secretaries and talked to commissioners who said that, Maharashtra, I think they said we have 70 pieces of software. Everybody comes up with, oh, here's a solution, right? And then they don't talk to each other and you're left with a whole bunch of these things. So we knew that was a problem. We said we'd come up with a comprehensive primary healthcare so that for an individual, they have a health record that looks at, the communicable, non-communicable, RCH, all aspects of healthcare in that one health record, right? That's that's kind of the aspirational thing. You can do that if you're working in a complete green space, right? When you're working with an NGO for complete controlled environment in their area. By the time we went to Andhra, I had demoed this comprehensive primary healthcare to Chandrababu Naidu, right? And he said, this is great, we'll try it out in Vizag district. But when I started having the detailed conversations with their team, they said, forget RCH, RCH is reproductive child health. We already have our own, that's the most mature part and most important part of the healthcare system. Majority of the budget goes in there and is the oldest. So they said, we already have a tech system for that. We want a tech system for something else. And that's how fragmentation happens. So we built it for communicable and non-communicable, right? We had to trim down a solution. Then when we went to the state level, they said, no, we have something else for this thing. This program is only for NCDs. Give us a solution for this. And that's how the fragmentation happens because there are line departments and each of them is responsible for a particular program. And that leads to all these things and these things don't talk. When we were doing this NCD, to the credit of all the senior people in Delhi, they were like, the reason we called it, if you saw CPHC NCD in the BBC video, CPHC NCD is Comprehensive Primary Healthcare NCD, saying that NCD is the first one, it's the first one in the comprehensive primary healthcare, but really the platform is going to be for all of primary healthcare. But that just didn't happen. We spent while we were doing this, I think in a couple of years, we would try to integrate with TB, we tried to integrate with RCH. Everybody was for it. The additional secretaries, the joint secretaries, the department people, but just the enormity of taking a massive nation scale system where the registries don't match, you don't have a common ID, and who's going to work on it? Everybody has their tight mandates. Who's going to do this thing which falls between gaps? So that's why all of these things, finally, we just said we don't have the bandwidth. It's a very important thing to do. All of us want, the intent was there. But now with ABDM, we are hoping that, not hoping, but that's the strategy, right? ABDM now says one unique health ID across all of these, and we've already integrated. So ABDM has a milestone 1, 2, 3, right? First, anyway, that's like more detailed thing. But so we've integrated with ABDM. Now, if the TB program is also integrated with ABDM, technically, and if there are, if a patient is actually using it, you can have exchange of data. So you don't need to have them running on the same IT system. The whole premise of this thing is you have a complete different NCD system, you have a complete different TB system, you have a completely different RCH system, but because you have common registries and you have a common health ID, and a consent manager that everybody now is compliant with, you can combine all of these. You still need to have a common user interface for the health worker so she can see the patient Himanshu's data from NCD and TB or whatever in one screen, right? That still requires some application this thing, but the data interoperability can happen through this DPI. I'm sorry if this is
So, Himanshu, let's let others go. And I think we can do in the reception time, we can ask other questions. So
this is
Felix,
complicated.
and then there's one question in the back. Yeah, go ahead.
Hi, I'm Felix. I built something like that. Company is called Tika Health. Tika was called vaccine in India. I built this when I was at Harvard Medical at the start of COVID. So basically, essentially, I wanted to build a platform which surrounds PHR, personalized health record, that will equate to precision medicine. I am in 6 countries: Taiwan, Hong Kong, India, Singapore, Argentina, and the US here. Essentially, it's like you have your medical record and you need to go to another country. Number one, nobody remembers the medication. Number 2, nobody remembers the drug allergy. Number 3, nobody remembers the chronic. If anyone comes into a hospital in the US, need medical care, the last thing on their mind, they will never remember all this. So what I wanted to do was to bring quality health, one, patient empowerment, 2, health equality, 3, health standards to raise to a level that everyone is equitable, whether you're rich or poor, you raise it up. I'm not Dell. I funded everything on my own.
Wow. That's pretty impressive.
I funded everything on my own. Anurag was very kind. He invited me to his hometown last November. It opened up my eyeballs. Never did I ever imagine, I was wondering why would people carry their luggages to see doctors? Everything was a big eye-opener for me. That a country like India, but then again, digitization was never there. People were storing 20 years of their medical records in suitcases. I was shocked. I was so shocked. Okay. And I told Anurag because he took me, and I'm grateful for him to open up my eyeballs. But in the last, never. Okay. And I went back to India again a couple of weeks ago, and I was grateful to an orthopedic surgeon who was trained in Singapore, and he took me around and Hyderabad, and there were a lot. I saw even more things that I never imagined. And there was consensus because I showed them, you know what, this is my platform, use it, play with it. I didn't even charge a cent. I don't charge. I funded everything, I built everything, and I still don't charge.
So Felix, do you have a question? Because I want to make sure. Yeah.
I have a question for you. In your case, how do you make money?
What's the business model?
Yeah.
What's the business model?
So for Dell, this is a part of our ESG initiative, CSR, right?
Okay, so
yeah.
you funded it internally.
Yes.
So
It was a philanthropic.
the important thing is, this is Dell's social contribution. So the important thing is we developed the software, and we as a technology partner provided the extended support around making that software functional. But the infrastructure came from the government, the devices came from government, the staff is obviously all government, the program is government, right? So this, I think, is another important thing that we discovered in terms of making these things sustainable when you're working. and a lot of lessons in this. If you go, you have to ensure that for the sustainability, you also don't go and do everything, right? There
Work with
has to
partners.
be ownership with from government. Eventually, this has to be in government. It's citizen data.
Yeah, so let me answer your question very quickly, and then we'll go to another one. You're a private sector partner, private sector organization. I think what ABDM does is provide the platform, and then as a for-profit organization, you provide solutions that fit on that work on with that. So you may want to start thinking about how Tika Health plugs into ABDM. I had mentioned this to you last time.
Yeah.
I think that's what you're hearing here as well. Government doesn't want you to not make money. Government wants partners from the private sector contributing to the solution of healthcare in India.
Yeah.
And the only way that's going to happen is if they provide that the public DPI and DPG, and then private sector organizations come and create something of value, something that brings value to the patients, to the doctors, to the healthcare system, and then you will be able to make money. So I know you had a question and you had a question. Whoever wants to, why don't you go first?
Sunita, you did a great job, and I'm so happy to hear this in person. My question is.
And you're not biased. No, we all agree, by the way.
Presentation between healthcare and transportation, it's kind of similar, and I kind of understood. I learned something how to work in India with that kind of situation. My question is around data. So, out of this data, luckily you're saying there's a digital public infrastructure, which I heard also. How do you have? Is there in this system? Is there people like policies set on the digital? And the other thing I have is around a bunch of questions, but to say, what insights you got out of this when it's implemented, whether it's women's health that needed more help, or versus a child help or
everything.
Those are
Both excellent questions, Usha, and I'm not biased either. From college, but so in terms of data security, data privacy, it's not India is actually fairly strong in terms of data privacy. They proposed something that was very much looking like GDPR, which is much stronger than what you have here.
Restrictive in many ways, yeah.
Very restrictive. It hasn't gone through. So it's a little bit of a gray area, but you have to assume that it's going to be pretty tight. And so we're building for that. But having said that, there is no HIPAA equivalent. So,
yeah.
And then
Can I just add quickly?
Yeah.
So HIPAA is in many ways rooted in where the technology used to be in the past, the way data structures were. In some ways, I think we need a slightly different version of it. And I'm hoping India thinks that through.
Yeah.
But yeah, please. Yeah.
And then the second question, what were the insights that we got, right? Yeah, I think the short answer is that, overall, I'm surprised with, for NCDs, because our focus has been on NCDs, that there is a lot more, there's a lot of NCD in the rural areas than we had even expected, and there is understanding of NCDs because, especially hypertension, diabetes, there is enough understanding and awareness now because people have seen somebody get a stroke, somebody getting paralyzed, and there is a little bit of fear on that. There is a tremendous amount of fear about cancers. So I remember earlier on, even to get women, I've gone to villages and I've asked, I want to be there for a particular screening when a woman is getting screened. And a husband was furious. He's like, why are you taking my wife for screening? Are you seeing, almost like if you screen her for cancer, you'll
find it there.
She doesn't have cancer, why do you have to go screen her, right? So there's like cancer is such a bad word there. It's a scary thing. So that I think is going to be hard. And also when people, I think that, and I've heard government officials and politicians talk so sensitively about this, that when you're trying to design a program, it can become very clinical. It can become very transactional, right?
Non-human.
Non-human. You say, okay, so the guidelines will say, you do clinical breast examination and you do oral visual examination. and you find this lesion, then you do this, and if you do this, then you do this, and you have that whole thing, right? But any one of those turning positive is devastating for the family, especially in rural areas, right? With cancer. So I remember the Andhra health minister, Srinivas, during Chandrababu Naidu's time, he was like, he was telling us, we were talking about all of this, and the software will allow you to do this, and you do this, and all that stuff. He said, just remember how devastating it is for a family to hear that there's potentially cancer. So he was actually pushing the health system to say, while you're doing all of this, make sure that there is enough emotional support provided to
That's
the
wonderful.
patients.
That's actually really
I think that was
That's remarkable. So I know you had a question, and then we'll end with you, and then we'll go break
I
for.
have one question. So
Yeah.
maybe
Okay.
can-
Okay, you want to end with that? I think why don't we do this during the break, because she'll be here. Okay, let's go ahead.
Right. The CSR work we did, who owns the IP on it, and is it open source?
Again, both very good questions. As a part of G20, we finally got it like completely open source and offered as a DPT to other countries. So this was a combination of, so when we signed the MOU with government, one of the conditions when government was interviewing, we're screening through everybody with their potential solutions, they said it has to be open source and it should come at no cost to government, right? And they can do that because it's government of India and everybody is vying to be their partner. In terms of IP, when we signed that MOU with government, it was owned by government, Dell, and Tata Trust. Tata Trust, because we worked with them as a partner and we had the MOU to government through Tata Trust for other reasons that I won't get into around here, it's too detailed. But the point is that this was implemented as per Government of India guidelines with Government of India experts. So it's not just about the technology that Dell developed, it was really co-created. So that was the IP part, and it is open source.
Okay, fascinating, right? I'm glad you're with me yesterday. Kudos to you for getting this done at this large scale, like one of the biggest populations in the world. But the technology is the easy part in all of this, right? The program development and how you implement it, the incentives, and so on must have been the interesting part of this, frankly. Did you have to change any of that? Like, for example, doctors are not the best in terms of entering data. How are we making sure that the data they are entering is good in some ways, or the ASHA workers, and did you change anything there in terms of the process and the incentives?
Like a lot of things. There's so many examples. So screening became a conditionality. I mentioned conditionality, I think, in the earlier part, right? Screening became a conditionality like in year 3 or something like that, right? Because otherwise it was just enrollment. And once it becomes a conditionality, then it's being reviewed in the budget.
Tracked,
you see that happening.
But
another thing we noticed,
fraud.
The fraud prevention is, it's again, this is the maturity that I was talking about, right? There was at one point, like I think about 2 years ago, government came up with an incentives, performance PLI, performance linked incentives scheme, right? So we had like months of deliberation on those things, along with the actual PLI design, which was coming from NHSRC from government, and then the corresponding technology to make that happen, right? Where they were going to, it was to prevent fraud, because money was going to be paid out for every hypertension screening, for diagnosis, for a follow-up, you get so much, right? So that was going to include a lot of this. It finally didn't get rolled out. And my point of bringing that up is to say that these are fairly complex, right? There is so much pushback, even to mandate to say that we will only consider data. This was thrown around that we will only consider data if it's coming in from a device, meaning if it's actually connected digitally. They can't pass it at a national level because health is first of all a universal subject, right? Just like when we're enrolling somebody, if they say they don't want to give their Aadhaar, you can't say I won't enroll you. You get slaughtered. I mean, that's not possible, right? It's a universal thing. So same thing, Government of India can't say that, oh, this state we won't release your budget because you didn't enter it digitally. No, right? Because it's a very political thing. So these things can't be pushed too drastically like that. So we keep on pushing our recommendations, telling the joint secretary, this is not happening, can you push it, and all that stuff, and then it will move very slowly, right? But things like fraud and all that stuff, because it's complicated, because it's political.
Can I say something? I mean, I've having seen China evolve last 20 years and India too, and India has in much shorter time achieved a lot more on digital health side. It's remarkable that a country that is democratic, very chaotic, very multiple stakeholders, everybody has a right to stop a thing, right? Everybody has a veto basically, versus a top-down system like China's. It's remarkable what India has achieved over the last 10 years. And thanks to partners like you who and forward-thinking political leaders in all states. I mean, it's not just one party or one government. So let's just end here. Let's just do a big round of applause for Sunita. And to all of you for amazing questions. You guys were great advice.
Thank you. I really love it.
Thank you. And thank you for making this happen.
No, thank you. Made it very engaging. So my closing remarks are, I mean, obviously, thank you, Anurag, because I think you brought a lot of gravitas to the evening's presentation as well. And I thank you as well for not just taking it on as my request, but the fact that there were a lot of people that were thirsting for this kind of information, want visibility into what you were saying. Hopefully we'll get more and more chances as we advance into this. I know you're very involved in water these days, so we'll probably take the next opportunity to discuss that.
Yeah. So and just to close on in case there's any water people interested in that. So I chair a foundation called Argyam, which was set up by Rohini Nilekani, Nanda Nilekani's wife, and I was the first CEO and now I'm the chairperson. And we are interestingly going through a very similar journey with Argyam, where we are looking at how every household can get access, how you can have water security for the vulnerable communities across India, and how you can use technology and partnership with government to ensure that this happens, water security at scale, by using technology to strengthen government programs that are delivering these services. So
there's a lot of parallels actually, so there's a diagnosis screening part and there's also an intervention part.
The water testing kits and
Totally.
then
So on that high note, we'll go from water to spirit. Thank you.
That was wonderful. Actually, I think Himanshu will have something very specific. Himanshu and Melissa, but I have something very specific. I mean, your advice and so.